So the name of my presentation is Physician Judgment versus Predicted Models in Outpatients with Heart Failure, Who is Right? So I don't have any disclosures to present or to make, but I would like to say that I'm presenting on behalf of Taylor Buchan, who is a PhD student working with us, specifically studying clinical epidemiology at McMaster, and she has been key in the execution of all of this research work. So why we measure prognosis? So I think that, or I believe strongly that accurate prognostic information is very important for patients and physicians to make optimal health and life decisions. So we can give here a couple of examples. So we can characterize heart failure, such as informing our patients about the probability of future events, or as well facilitating communication with colleagues about the prognosis of our patients of the risk of events, especially in colleagues from different specialties. We can define a therapeutic plan, trying to avoid delays in treatment of high-risk patients, but also preventing over-treating low-risk patients. And of course, we can facilitate research specifically, for example, exploring the subgroup effect of a medication based on patient risk. So estimating prognosis in heart failure is very complex, and I think that this is not news to you. And the standard practice relies on physician judgment, which has proven to be suboptimal. So the alternative approach is the use of predicted models. To me, the model has to have two specific qualities. One is to have good discrimination, which means to be able to distinguish between low and high-risk patients, but the discrimination doesn't tell us if the difference between low and high is 1% or 50%, which here brings to our attention the second quality, which to me is the most important one, which is the model has to have good calibration if we care about the prediction of absolute risk. Good calibration means that the predicted risk is very close to the observed risk. So here in this example, for example, the MAGIC score, a score to predict mortality in heart failure patients, predicts very well in patients who are at low risk, but starts to underestimate risk in patients whose risk is 15% or higher, which is miscalibrated in high-risk patients, and that could be a problem depending on the decision that we are trying to make. So the question that we pose here and that we have been trying to answer in the last year is physician judgment more accurate than models to predict mortality in patients with heart failure? So we define our work in 3 stages. So the first objective was to compare the accuracy of physicians versus model predictions to estimate 1-year mortality. The second work was to assess whether the accuracy of physicians differs based on patient and physician characteristics. And the third one is to evaluate whether the integration of physician and model predictions improves prognostic accuracy. So for all of these studies, we conducted a prospective cohort study, including multiple clinics, 11 heart function clinics in 5 provinces in Canada, including only patients with reduced ejection fraction for a total number of 1,650 patients enrolled between 2018 and 2020. We followed these patients for 1 year. At the time of enrollment, we asked family doctors and heart failure cardiologists to record in a closed survey 1-year predicted mortality according to their judgment, and we also calculated this 1-year predicted mortality by the Seattle heart failure model, and we chose that model based on some specific criteria. So this study included 50 heart failure cardiologists and 850 family physicians. So the population was very similar to any other population with reduced ejection fraction. Patients were on very good medical therapy, and the 1-year mortality was around 10%. So the main statistical analysis of objective number 1, which was to compare the accuracy of physicians and models, was Cox proportional hazard models, specifically evaluating discrimination and calibration, and we stratified the analysis by heart failure cardiologists and family doctors. This is the main findings of all of this work. So the upper graph shows the performance of the Seattle heart failure model with a C-statistic of 0.76 and excellent calibration based on the comparison between the red line, which is the predicted mortality by the Seattle, and the green line, which is the observed risk at 1 year. And there was a little bit of risk overestimation in the highest risk decile. While heart failure cardiologists who are in the middle graph, purple line, show very good discrimination, C-statistic of 0.75, but significantly risk overestimation from low to very high risk patients, and family doctors more or less the same with significant risk overestimation. So what we tried to understand was factor impacting the accuracy of physicians. Probably physicians were better or more accurate in some subgroups. So for this, we define concordance or accuracy of physicians by estimating the difference in risk between model and physician predictions. If the risk was within 10%, that was concordant. If it was outside the 10%, that were discordant. And we did multivariable logistic regression to evaluate multiple physician and patient factors. What we observe as a main finding is that the higher the risk of our patients, the higher the proportion of discordant results, the higher the differences between models and physician predictions. When we evaluated this in multivariable analysis, we observed that in addition to the risk of our patients, we observed that sometimes, so predictions from Black patients on when female physicians were making prediction on male patients, the concordance between models and physicians was lower. And what we observed, that we thought that that was going to be the case, when physicians were more confident in their estimates, concordance was higher. So we say, there you go. That's what we have to do. When physicians are super confident, they can use their own judgment. When they are not, they can use them all. So we did a sensitivity analysis evaluating performance in these high confidence estimates, but we observed exactly the same limitations. So physicians had adequate discrimination, heart failure cardiologists, poor discrimination, family doctors, but again, with significant risk of overestimation, even when they were super confident about their judgment. So this led us to these two, and then to the third objective, which is doctor can discriminate, but they significantly overestimate risk. Estimates from models are more accurate. So what about the integration of these two tools or ways to assess prognosis? So this is the third objective, the same outcome, 1-year mortality. We did two types of integration. One was using the Cox proportional model to assess the independent value of these two ways to prognosticate, and the other one was with the random survival forest that allows more flexibility between these two variables. We assessed discrimination, calibration, and here we started also to pay attention to risk reclassification and net clinical benefit. So the same results as previously, so the Seattle was good to estimate and to discriminate and very well calibrated. Heart failure cardiologists, as we knew, overestimate risk, but when we integrated both of them, discrimination was much better, a statistic of 0.82, and calibration was almost perfect. This model was recalibrated in this population, so these two metrics could be overestimated. But a point of interest is that these two factors, so physicians and models, were independently associated with prognosis, adding some additional independent value. So when we evaluated net reclassification improvement, what we observed is that by using the model, the Seattle heart failure model alone, or the integrated model, we better reclassify patients without event, but we worse reclassify patients with events. But on the net, because patients without events were much more frequent, using the model led to better risk reclassification, 43%, or 61% if we integrated both ways to prognosticate. So every clinical decision has trade-off or disadvantages. So for example, I have put some examples here: diagnosing cardiac sarcoidosis versus doing an unnecessary biopsy, saving a life with a heart transplant versus transplanting too early, reducing the risk of hospitalization versus complicating care, referring patients to heart failure clinics versus overwhelming the system. Every time that we do something, we may expose patients to some disadvantage. So when the risk, the absolute risk gain is significant, we pay more attention to the benefits and not too much to the harm. But when the absolute risk reduction is not that much, we pay more attention to the harms. And so that's the case, for example, in low-risk patients. So the net clinical benefit is try to balance these two advantages and disadvantages. So net benefit is when we treat patients, more patients correctly than incorrectly. The balance between treating patients correctly and incorrectly depends on the consequences of the medical decision. For example, we use folic acid in every single pregnant woman to probably prevent one bifid spine in 1 million patients. We treat like the other almost 1 million patients with folic acid unnecessarily, but it's worth it because the risk of that intervention is minimal. But when we are discussing, for example, heart transplant, our risk threshold increases from almost 1% to 15%. We would only proceed with heart transplant if the risk of our patient is 15% or higher. So in that case, when we put this into context, when the risk threshold is 5% or lower, we can make a decision, we can guide our decisions with our judgment or the model, and it wouldn't lead to any difference in the net clinical benefit. But when our decision involves a decision threshold 5% or higher, using the model or the integrated model would lead to more clinical benefit, treating more patients currently than incurrently. And in fact, when the risk threshold is 15% or higher, using only our judgment will lead to more harm than benefit. So with summary points, I think I would like to say that risk stratification and prognostication could be very important if we think that deciding based on absolute risk of our patient is important. In this study that we simultaneously compare physicians and models were more accurate. The main problem was that physicians tend to overestimate. And the main advantage of using a model is to prevent overtreatment of some patients, exposing them to harm, cost, and higher use of resources. And with that, I would like to thank my team, the funding sources, all the collaborators, and we leave questions for the end.